Thanks, Dr. Chow. Thanks, everyone, for having me today to do these rounds. So today I'll be going over the anatomy, function, and role of the left atrial appendage in pathophysiology. We'll talk about some of the closure techniques that exist, discuss some of the evidence surrounding the efficacy and safety of percutaneous left atrial appendage occlusion, talk about the procedure itself, some of the complications and post-procedural management, of which echo plays a very important role, and then go over some of the future directions in this field. So the left atrial appendage, it's been called our most lethal human attachment. And why is that? So first of all, we'll take a step back and chat about the anatomy of the left atrial appendage. So this is some images of the gross anatomy of the left atrial appendage. And we can see it here in the first panel, its proximity to the great cardiac vein. In the second panel, when the left atrial appendage is retracted, we see how closely it courses to the left circumflex artery. In the third panel, when we see the left atrial appendage transected, we can see where the os is. We can see how it tapers along its length. And again, we can see its proximity to some of the pulmonary veins as well as the mitral valve. We can see how the smooth myocardium of the left atrium transitions into something that's more rough, and that there's a ridge in between the two. And then again, another view posteriorly of the left atrial appendage, again showing the os, the diameter of the os, and the body of the left atrial appendage. So this gives us context for the structure that we're talking about today. Again, another gross anatomical specimen, giving us a bit more detail of what the left atrial appendage itself looks like. It has an ostium, it has a neck, a body, and then a number of lobes depending on the morphology of the left atrial appendage. And here's what it looks like on echo. So again, we have the ostium, the neck, the body, and number of lobes. You can see this is quite a complex structure. In terms of morphology of the left atrial appendage, a number of them have been described, and this is what gives the talk its name. These are the different morphologies and how they look on CT. So the most common is the chicken wing morphology, actually. Almost 50% of cases are chicken wing morphology. And this is characterized by a main lobe that has a bend in it, and then it can have secondary lobes as well. We also have a cactus morphology, which is characterized by a main lobe and then multiple secondary lobes coming off of it. The Windsock morphology, which has a long main lobe followed by secondary lobes. And then the cauliflower morphology that has complex internal characteristics, and you can see it doesn't clearly have secondary lobe, but it's very kind of rough surface. And this is what the morphology looks like on TE for the most common one. So again, the most common being the chicken wing morphology with its main bend in the lobe, the Windsock with its long body and number of possible secondary lobes, and the cactus with a shorter main body and number of secondary lobes. So in addition to anatomical traits, the left atrial appendage also does have a mechanical function. So it does actually contract. It's not just a passive structure. And so by using a PW wave through the first 1/3 of the left atrial appendage, we can look at the velocity flow through the left atrial appendage. And there's a difference in the flow when the heart is in sinus rhythm versus in atrial fibrillation. So in sinus rhythm, the left atrial appendage has a quadriphasic flow pattern. So first we see this wave that's corresponding with the left atrial appendage contraction, followed by a second wave that corresponds to left atrial filling velocity. During systole, we have reflection waves, so small waves on both sides of the line, and then followed by early diastole, where we have left atrial appendage flow back into the left atrium. In atrial fibrillation, however, what we see is more of a sawtooth signal, and the amplitudes vary, and generally the velocity is also slower compared to sinus rhythm. And there's been a number of studies looking at factors that are associated with lower flow through the left atrial appendage as well. That in addition to rhythm, there's other factors including increasing age, female sex, larger left atrial appendage size, increased left atrial pressure, impaired relaxation of the LV, as well as those morphologies that we discussed. So the cactus and the cauliflower morphology being associated with slower flow of left atrial appendage. There's hypothesized to be a neuroendocrine function of the left atrial appendage as well. So people believe that it actually secretes hormones. And the evidence that they have for this is based on measurement of hormonal levels after exclusion of the left atrial appendage. So either through surgical excision versus percutaneous exclusion. And what they found was that there was no change with percutaneous occlusion, but when it was surgically excised, there were lower levels of adrenaline, noradrenaline, as well as hormones in the RAS pathway. And the ANP and BNP also decreased, but subsequently normalized at 3 and 6 months. And then there's also an arrhythmogenic role. So as I mentioned, there's a discontinuity between the myocardium as it transitions from the smooth surface of the left atrium to the left atrial appendage. And it's believed to be a substrate for arrhythmia as well. So there's been some targets along this structure in atrial fibrillation ablation as well. Probably the most important role in pathophysiology for the left atrial appendage is its role in thrombogenesis. So this was really brought to the attention of the medical community after a seminal systematic review that was published in 1996 by Blackshear and Odell. And this really emphasized the role of the left atrial appendage as a nidus for thrombus formation. And so what they did was they looked at reviews of at studies of patients who were in atrial fibrillation and had some kind of study, whether it be echo, autopsy, or OR, to see where the thrombus was localized to. And for patients with non-valvular AFib, the thrombus was actually localized to the left atrial appendage 91% of time. And for valvular AFib, 57% of the time to the left atrial appendage. So this is a very important structure when it comes to clot formation in the context of atrial fibrillation. And so there's been studies looking at, in addition to the traditional risk factors for stroke and atrial fibrillation, how does the left atrial appendage characteristics also contribute to it? So on the left side here in the green, we have kind of those traditional risk factors that we think about when we're risk stratifying people with atrial fibrillation and what is their risk of developing stroke. And then on the right in blue, we have the characteristics that are specific to the left atrial appendage, and they're very similar to the characteristics that I spoke about in terms of slower velocity through the left atrial appendage. So things like increased trabeculations, non-chicken wing morphologies, increased left atrial appendage volume, increased os size, increased fibrosis, and endothelial dysfunction. And these are all subjects of ongoing study in terms of their risk contribution to stroke. So clot or not, this is the question that's often posed to the echo team. And we know that the left atrial appendage can be seen on the transthoracic echo sometimes in this short axis or the two-chamber view, but Real-AT is gold standard to adequately visualize the left atrial appendage. And we use it before procedures such as cardioversion, before AFib ablation, before left atrial appendage closure, because an LAA clot would be a contraindication to these procedures. And it requires a very detailed examination of all the lobes in the different planes, given the complex anatomy of the left atrial appendage. And looking for a clot, evidence of a clot itself, but also left atrial appendage spontaneous echo contrast, which is a swirling essentially in the left atrial appendage that's suggestive of slow flow and portends a higher risk of thromboembolism. So here we have a loop from TEE showing a rather large left atrial appendage clot in the left atrial appendage, and I believe this was an outpatient being assessed for severe TR, but this was found incidentally, and this is an important part of the routine TEE. And so an urgent call was placed to the patient's community cardiologist to let them know that if they're not on anticoagulation, they probably should be. This is a patient that I saw in the CCU. So this is a patient with new onset atrial fibrillation. They were going very fast and were actually quite unstable. And so we wanted to cardiover this patient. And so we called our friendly neighborhood echo fellow, Flora, who came and helped us to do a TE in the CCU. And then this showed up, and we were all staring at it, wondering what it was. This rather large figure. We've got the pads on the patient. We're ready to press the button and cardioverse, but what in the world is this? And so Flora injected some contrast for us, and this was the result. So no filling defect in the left atrial appendage, and so she gave us the thumbs up. Go ahead, you can cardiovert. We pressed the button, and then Flora decided to look again, which I was a bit concerned by, but she announced that the same artifact was still there. So definitely artifact. Thanks, Flora.
And patient did well after.
Patient did well afterwards. There was no stroke. It was all good.
Most important.
And successfully converted out of atrial fibrillation. And then this is a still image of spontaneous echo contrast, what it looks like. So this is the swirling kind of pattern that you would see associated with silver flow, and many cardiologists would also anticoagulate based on this finding and would postpone any procedures like cardioversion. So now moving on to talking about left atrial appendage closure in its different forms. So left atrial appendage closure, it was first described by Madden in 1949. This was a case series of two patients who had rheumatic mitral stenosis. They were undergoing cardiac surgery, and so they also underwent left atrial appendage excision as a prophylaxis against recurrent atrial thrombus. And now today there's different forms of surgical closure of the left atrial appendage that exist. So there's commercial devices that can work, epicardial device closures, staple kind of occlusions, amputation followed by suturing close of the stump, which the surgeons can choose from. Briefly going over the evidence of this, evidence for the benefit of surgical excision of the left atrial appendage comes from the LAOS-3 trial published in 2021 in the New England Journal of Medicine. This looked at patients who had AFib and were undergoing cardiac surgery, and they underwent simultaneous surgical left atrial appendage occlusion, and they wanted to see if this would decrease stroke. So they randomized, this was quite a big trial, 4,811 patients. Importantly, all patients continue to have anticoagulation, whether or not they had the left atrial appendage occlusion. And the main outcome they were looking at was ischemic stroke or systemic embolism. And this was a positive trial, so it showed that occluding the left atrial appendage while continuing on anticoagulation resulted in decreased strokes. So very promising trial there. And then percutaneous left atrial appendage occlusion is kind of the main focus of today. This is the procedure that very much relies on echocardiography. And these are the different, a couple of the different devices that are used here in Canada. So on the left, A and B are the Watchman devices. So A is the legacy device, so it's no longer implanted, but we have patients who have this implanted. B is the more current Watchman device, the Watchman FLX, that's currently being implanted. In Toronto, I believe they implant this at Sunnybrook, and they're starting to implant this here at St. Mike's as well. And then C is the Amplatz or amulet device, which is primarily the one that's implanted here at St. Mike's. And you can see that in the Watchman device, we have a frame that's made of nitinol and then a polyethylene mesh fabric over it. There's hooks that are maybe a bit hard to see along the edge of the fabric here that are fixation hooks that go to the left atrial appendage to prevent device embolization. And you can see some of the updates that they made between A and B. They made both sides closed. This was supposed to prevent less trauma to the left atrial appendage, decrease the rates of perforation and tamponade. And they added a second layer of hooks to reduce device embolization. C, the amulet device, is actually the device that's used in closing ASDs and PFOs. So they borrowed the same technology towards occluding the left atrial appendage. And it's a device that has two components. So it has a disc and a lobe that's used to occlude the left atrial appendage. And briefly, what does the procedure look like? So these devices are introduced through a femoral approach. They do have to cross the septum from the right atrium to the left atrium. Patients are anticoagulated during this time. They're given fluids to ensure that they have adequate volume loading to make sure that the sizing of the device is correct, because the sizing is very important. And then they're delivered through 12 to 14 French sheets. And this is on the right, what it looks like, the schematic of the amulet device going in. So briefly, I wanted to talk about some of the evidence for the left atrial appendage occlusion. Why is it that we do this procedure? So the first big trial looking at this was the PROTECT AF trial in 2009. And this asked the question among patients with non-valvular AFib, did closure with a Watchman device, was it non-inferior compared to warfarin? And so they randomized 700 patients, 2-to-1 to left atrial appendage closure versus warfarin. A very important part of the protocol, which translates into practice, was that patients would get a routine TEE at 45 days after the procedure. And if there was complete closure of the left atrial appendage, or if there's a small enough peri-device flow jet, less than 5 millimeters, then they would go ahead and stop that patient's warfarin. So that was a very important mark that translates into a lot of institutions' protocols for how they do left atrial appendage closure. They're mainly looking at stroke, unexplained death or CV death, and systemic embolism. And this was a non-inferiority trial. And so this trial did meet its criteria for non-inferiority compared to warfarin. The problem though was that there was actually more ischemic strokes in the Watchman group, which was kind of concerning, because the whole point of this procedure is to prevent strokes from the atrial fibrillation. So why was there more ischemic strokes? The authors thought it was peri-procedural related. So we do know that patients going for procedures on the left side of the heart are at higher risk of stroke. They thought actually a lot of it had to do with embolism, or perhaps with movement of sludge or clot when the devices were in there. The other concerning thing was there was, 4.8% of patients in the intervention group had a pericardial effusion after the procedure. So taking into account these complications, the FDA was concerned enough. They asked the authors of this trial to go back, do it again, collect more data. And so the same authors did the PREVAIL trial, published in 2014, pretty much asking the same question. They were just asking for more data at this point. The one main change was that this time they focused on patients with CHAD score greater than or equal to 2, or CHADS1 with some other higher risk characteristic. So making sure that these patients were actually at risk of stroke. If we're going to expose these people to a procedural risk, they should actually have a strong indication for it. And this probably aligns more with our current practice of who we're considering to put these devices in. We looked at the same primary outcome. This trial actually didn't meet its non-inferiority outcome. So the numbers were very similar, numerically slightly higher rate of events in the device group. The one caveat was that the ischemic strokes were still higher in the device group, but less of a difference compared to the previous trial. And then this was always meant to be a combination of patients to get a larger sample size. And when they combined all the patients, they said, look, yes, numerically, there's still more strokes in the Watchman group, but there's less hemorrhagic strokes. There's less all-cause death and less major bleeding, favoring the Watchman device overall, they concluded. And we can see that from the first trial to the second trial, the percentage of implantation success went up, percentage of complications went down, so probably reflecting more experience in putting in these devices. And then the last trial that I want to talk about was looking at the use of this device in patients compared to DOACs. So those first two trials looked at warfarin because of the timeline of when those trials were done, but we don't really use that routinely anymore for non-valvular AFib. So this trial looked at it compared to DOAC, looking at a large primary outcome composite of multiple things, and they met their criteria for non-inferiority. And so based on that, the CCS does recommend that percutaneous left atrial appendage closure can be considered for stroke prevention in patients with non-valvular AFib who are at risk of stroke and have absolute contraindications to anticoagulation. Weak recommendation, low quality evidence, based on what I've presented. So now chatting about the role of echocardiography in percutaneous left atrial appendage closure. So a very important role in this procedure in the pre-procedure phase, in guiding the procedure itself, and in post-procedural monitoring. So in terms of pre-procedural imaging, the echo is used to decide whether it's feasible at all to implant this device, and also to help plan the procedure itself. So as I mentioned before, detection of any thrombus in the left atrial appendage or left atrium is very important. It's a contraindication to the procedure. Also determining the dimensions and the morphology is very important for sizing the device appropriately. So looking at the orifice diameter, looking at the LAA depth, so along the main lobe, and then also the depths of any secondary lobes. So if there's a secondary lobe that's too close to the orifice, there's a chance that could not be completely occluded by the device and lead to a device leak. And each of the devices themselves have their own type of anatomical indications and contraindications. So some patients might be eligible for a Watchman device, but might not be eligible for an amulet device, and vice versa, dependent on their anatomy. Other potential contraindications include an atrial septal aneurysm, given that it is a transseptal procedure, and that might increase the risk of doing the procedure and increase its complexity. And then if there's a large interatrial shunt. So the gold standard for pre-procedural imaging and sizing is the TE currently. Though there is a caveat that it may underestimate the true left atrial appendage diameter. And so, for example, for the Watchman device, the company has published the protocol that the sizing should be measured at 0, 45, 90, 100 degrees for adequate sizing. And this is what it looks like on TE, the measurements of both the diameter and the depth in each of these angles. Cardiac CT is increasingly being used as well for pre-procedural assessment. So this is what it looks like on the right, where they're able to look at the diameter of the left atrial appendage in order to choose the correct sizing. So in this case, the ostial diameter was 22 millimeters. And so the device size that they selected was 24 millimeters. Usually device size is a bit larger to ensure adequate compression against the left atrial appendage. And then intraprocedural imaging also involves echo. So in panel D here, we have the fluoroscopy image, which is also used to guide the procedure in conjunction with echo. Originally, the procedure was done mostly with transesophageal echo, and currently there's more increased use of intracardiac echo as well, with the benefit that the patient doesn't need general anesthesia, and so the patient might be able to they might be able to do more cases or decrease the risk that comes with general anesthetic. There's a lot of innovations happening in this area for intraprocedural guidance. This is showing some images from TE to guide the transseptal portion of the procedure. So looking at the intra-atrial septum at two levels, one, the short axis at the level of the aortic valve, and then also at the level of the IVC and SVC. And the area that they're trying to target is the inferior posterior wall of the atrial septum, which is anatomically the best way that they can get towards the left atrial appendage. And then, as I mentioned, post-procedural follow-up is also very important. So based on that study protocol, the TE is routinely performed at 45 days after closure to assess the position of the device, stability of the device, assess for any peri-device leaks, any device-related thrombus, pericardial effusion, and iatrogenic ASD. And then usually most institutions are stopping anticoagulation after the 45-day TE if criteria are met. So this was a left atrial appendage closure that was done here at St. Mike's with the amulet device. So we can see here the disc is the part of it that's seen the best. And then here we have also with color on TE, with the scale reduced to 23 to look for any lower velocity flow around the device that could indicate peri-device leak. And this device appears to be well seated with no evidence of device leak around the device or through the device. So a good result. And this is the 3D images on TE, again showing the amulet device on FAS. And this is looking at it from the left atrium. And again, we can apply color to look for any peri-device leak or intra-device leak. Again, looking like a good result. So one of the important complications to look for is device-related thrombus. So the incidence of this, about 3.7% based on the trial registry data, usually occurs within a year for 57% of the cases. So we'll pick up some of them at the 45-day TE, but not all of them. It's associated with increased stroke risk, as you can imagine, and very tricky to manage because the patients that we're putting these in are at higher bleeding risk, so putting them on blood thinners can pose a challenge. This is what it looks like on CT. You can see the device thrombus there, the shadowing there, and then on TE as well. The arrow pointing to where the clot is, more clearly probably seen in this image, sitting on the device. Device leak, as I mentioned, and there's different mechanisms of leak that can happen. So if the device is not well opposed to the ostium, you can have leak around the edge. If there was a secondary lobe that was too close to the ostium, that can result in a whole lobe being uncovered and causing leak around it. Same with having some tissue at the left atrial appendage proximally that can be uncovered. And then fabric leak, so leak actually straight through the device. And these are TE images showing, again, flow through around the device. This is a rather large peri-device leak. And then seen again in the on-FAS view in 3D, a rather large gap there. So why are device leaks important? Their incidence fairly high depending on which trial you look at, between 8% to 55%, and it has been associated with increased ischemic events. So briefly talking about some of the innovations that are happening in left atrial appendage closure technology. So there's new devices being explored. This is a preclinical result of a new device that would go in, twist, and seal off the left atrial appendage and really leave just this small residual piece on the left atrium wall. The idea being that, you expose as little as possible and decrease the risk of thrombus formation. So we'll see where this one goes. There's lots of innovations happening in the imaging and pre-procedural planning. So being able to virtually implant these devices at different sizes to see what the effects are. And some groups using 3D printing technology to really understand the anatomy as well as how the device will fit prior to implantation. Again, improving safety and efficiency, a lot of work going into ICE in order to improve the time at which it takes to do these procedures, turnover of the rooms, and try and make it so that it's feasible to do more cases. And then in terms of patient selection as well, so there's lots of ongoing clinical trials. They're looking at comparing the device to DOACs, so more trials looking at DOACs because it's more aligned with our current practice. Trials looking at patients who have contraindications to anticoagulation, which is how we use the device really. But in all of the previous trials, this was not actually what was studied. So they're looking at patients who have kidney disease, who have had brain bleeds, patients who might really benefit from this. And then patients, receiving both the device as well as anticoagulation, since this was the very good result in the LAOS-3 trial. So in summary, what's happening? Okay. So left atrial appendage structure and function, pathophysiology is best assessed using TEE. The closure of the left atrial appendage with percutaneous devices has been shown to be non-inferior to anticoagulation for patients who have non-valvular AFib, who are at high stroke risk and high bleeding risk. And echo is a very important part of the pre-procedural planning, the in-procedural guidance, as well as the post-procedural monitoring. So thank you, everybody. Happy to chat.
So thank you, Magdalene. It's often one wonders why we have all these appendages. So we have appendix, which we only cause problems and really doesn't do much, by and large, for our human beings' existence. And left atrial appendage often puzzles me about why it actually exists. So you gave some reasons why it exists, but interestingly, over the evolution, we still have them in our body. But be that as it may, it causes more trouble than it's worth at this point. So we often include them when it's needed. So thank you for reviewing it. I think from a sonographer's point of view, the importance is we often, in the post-procedure, we get involved, like the day after, to look for complications, especially pericardial effusions, etc. Those are the time when we see them. And also the other challenge that we face when patients come back with these devices, often you get a shadow on the four-chamber view where the left atrial appendage would be, and you get these funny, bright things, and you didn't have a good history, you'll be like, what the? In that area, right? So those are all the situations. The other place that you would see it on transthoracic when you have these devices would be in the short axis, where, especially the left atrium is huge. You get this, what we call the snowman sign, where there's a little arm coming out, and that's where you will see the device as well. So sometimes when we start reading, it's like, oh, what is that bright thing? So you need to actually go back to history, or even ask the patient, it's like, what has happened to you? And that type of thing. So I think those are what sonographers have to watch out both, within a hospital setting as well as community setting, because there's a lot more of these people going around. The other thing that I felt is important is the advance of ICE. And ICE, which is an intracardiac echo, has been around for about 25 years. So initially it was actually developed in the United States in Mayo, and it's really just mounting a monoplane echo onto a tip of a device, which is like tiny, about 9 French initially, that you can get in and actually look around. And now pretty much a lot of procedures as you see the development, initially will be guided by TEE, and then it's ICE, and now mini TEs. So, it fluctuates back and forth, but the advantage of using ICE is that you don't need anesthesiology, and, interventions can do it all by themselves. So it's safe on that. In certain, cost self-conscious environment, that we actually save a bunch of cost. But on the other hand, the device itself is very expensive. So the ICE is ranging in between 5,000 to 8,000, although, there are ways to recycle them or reclean them. So there are FDA-approved method of doing that. So you can use a ICE for about 5 to 8 times, somewhere around that range. So those are the sort of the observations.